Hello, friends. Welcome to Parkinson's EmPower Talks, a journey of empowerment and understanding for living your best life with Parkinson's. Kick back, relax, and get comfortable. We're here to make your Parkinson's journey just a little bit easier. I'm your host, Daisy Reimer. I'm a nurse practitioner specialized in movement disorders and the director of medical advising and education for the Wisconsin Parkinson Association. The Wisconsin Parkinson Association's mission is to provide hope, community, support, and resources for people with Parkinson's and their loved ones. Today, we're going to be discussing deep brain stimulation, and my special guest is Dr. Taylor Finseth. He's a movement disorder specialist at Aurora St. Luke's Medical Center. And I just welcome you today, Dr. Finseth. I appreciate you taking the time out of your busy schedule. Give us a little bit of background on your education and how you became interested in specializing in movement disorders.
Sure. So I went to medical school at Ohio State and then did my neurology residency and fellowship at the University of Colorado, and then have been here at Aurora ever since. And I currently serve as the movement disorder medical director for Aurora and work at St. Luke's. I became interested actually after a conference that I went to my first year of neurology residency. And was just kind of fascinated by the field with the wide variety of abnormal movements and our ability to help people with those. And just kind of grew from there. And I've really enjoyed doing this and helping our Parkinson's population deal with the illness.
Mm-hmm. And you're also a distinguished member of our medical advisory committee for the Wisconsin Parkinson Association. So we absolutely appreciate your input in that realm as well. Well, let's go ahead and start talking a little bit. What is deep brain stimulation? People hear about it, but they don't always know exactly what that means.
Sure. So, it is what it says. It's applying stimulation to certain areas of the brain to try and change their activity. And as far as what we would talk about today would be applying deep brain stimulation in patients with Parkinson's disease. And we'd be aiming to disrupt some of the abnormal activity that occurs in a circuit in the brain called the basal ganglia. We do know that within the disease that certain areas become overactive and have abnormally synchronous activity that is going at a kind of an altered frequency, and we can use leads that have electrodes on them to stimulate that precise area and be able to help people with their movement symptoms.
Mm-hmm. So it's a surgical procedure. And then can you explain a little bit about the battery pack and kind of how that looks a little bit?
Sure. So in order to apply this stimulation, you have to have an implantation of a device, and that device would really have kind of three components. One would be the lead that goes within the skull into this deep area of the brain. That is placed by a special neurosurgeon who's trained in stereotactic techniques to get it to the right spot. They do have to drill a hole in the skull to place that. And then there is also a battery pack, and it generates the impulses that are needed to deliver the stimulation that would sit in the chest. And then those two components are connected by a wire. And the wire runs under the skin and kind of run behind the ear and down the neck to the chest to connect those two components. And everything is, all under the skin. There's no external components to the device.
Super. I know a lot of times people say, well, how do I get the stimulation? Where does it come from? And they don't really have that. I was actually recently speaking at a support group, and they didn't know if this was external or internal. So,
Yeah, and a lot of times the images that we use to explain it, it kind
mhm,
of looks like it's external.
right,
It is important to know, once it's in, it's all kind of part of you. You don't
right.
it
Much like a heart pacemaker,
right,
but
right,
always giving the electrical impulse.
correct.
Mhm. Good, super. So there are obviously different symptoms that this is controlling, correct? And so for a person who has Parkinson's disease, how does that procedure actually like control the symptoms, and like what symptoms do they control?
Sure. So the uh symptoms that arise from the abnormal activity within these circuits are, the main hallmark symptoms of Parkinson's disease. So this would be a difficulty moving,
Mhm.
where your movements are smaller and slower, and that's called bradykinesia, as well as stiffness of the muscles called rigidity, and then uh, many people with Parkinson's have tremor,
Mhm.
and it can also help control tremor.
Mhm.
Um, the deep brain stimulation, often uh, controls symptoms similar to how carbidopa-levodopa would control symptoms. So, in terms of the impact on the stiffness and the slowness, we usually use how somebody has responded to carbidopa-levodopa to help predict how they would respond to the deep brain stimulation. The deep brain stimulation is, however, a more consistent way to control those symptoms, and is a more effective tremor treatment than carbidopa-levodopa.
Mhm.
And that is one of the reasons we might do deep brain stimulation, is if somebody had hard to control tremor.
Mhm.
There are sometimes some benefits to some of the non-movement related symptoms of Parkinson's disease. That can be a little harder to predict, but there are good studies, showing that comparing patients' non-movement symptoms before and after, we often do see benefits to some of the other symptoms as well.
Mhm. And then, so oftentimes we hear, like with the medication, like carbidopa, levodopa, that the effectiveness can kind of wear off over time. Is that true also with deep brain stimulation, or is it forever?
Sure. So, it is important to know that while the deep brain stimulation is a powerful tool to control symptoms, that it's not a cure for the illness.
Mhm.
And and the longer somebody has Parkinson's disease, the more likely they are to get some of the um, more disruptive symptoms, like cognitive issues and dementia, or to develop a certain type of balance problem where they can have trouble with falling backwards, or speech and swallowing issues.
Mhm.
Um, those are generally symptoms that don't respond to carbidopa-levodopa, and they're not going to respond to the stimulation.
Mhm.
Um, and so, if somebody has deep brain stimulation, this doesn't protect them from getting those symptoms, 5 or 10 years or 15 years down the line. And so when people get those other symptoms, those can be the main determinant of what somebody's quality of life would be. And so we might expect some of the initial quality of life gains that occur after somebody has the surgery to be lost over time due to the progression of those symptoms. That being said, both carbidopa-levodopa and deep brain stimulation, remain effective for patients in controlling certain symptoms. I think they, if somebody has a carbidopa-levodopa response, early in their disease course, they're going to continue to have benefits to the drug. They don't become tolerant to it.
Right.
And so those main symptoms of slowness and stiffness, as well as tremor, they're going to continue to be controlled by deep brain stimulation over time. It would really be whether they're developing other symptoms, that are not medicine or stimulation responsive, as to what can sometimes lead people to say that, some of those benefits wore out.
Right. Right.
Yeah.
Good. So there are three different types of stimulators that can be used, or different devices that can be implanted. Do you want to kind of tell us like what you normally use or what you normally see, and then why would people kind of choose what would make you decide between the three different devices that are out there?
Sure. So the deep brain stimulators are all they're more similar than they are dissimilar. They all provide the same um, kind of technique of applying stimulation, and but they're different companies that provide these, and have some differences in their designs and in their features. So it's kind of like choosing between, different cars. It would sort of what is important to you. And there are some advantages and disadvantages to the different companies. Um, the three companies are Medtronic, Boston Scientific, and Abbott. And I would say that all three devices are very good. And there has been improvements to DBS devices over the last 5 years or so. And I think it's been good to have competition in the market as they keep pushing each other to get better.
Right.
We offer all three devices, and really don't have a strong preference, as to which device a patient might opt for, because we believe they're all good. It is true that if you depend on who you work with to have DBS, but some providers do have a clear preference for certain devices, and so I think it is a kind of a shared decision between the provider, who may have some preferences, and the patient. As far as kind of talking of, sort of like an overview of what is good about the different devices. So Medtronic has been, they kind of have been the leader in DBS for, a long time. They, before, about 5 years ago, they were the only company that did it. So they have a long track record, and then they're the only device where the electrodes actually are able to sense the abnormal brain signals, and that can be used to kind of target where to stimulate. And I have used that and find it to be a useful tool. Boston Scientific has some good imaging guidance for the provider, where we can actually see where the lead is in the brain, and that can help us with determining where to place the stimulation. And then Abbott, probably has the best rechargeable battery in terms of reduced frequency of needing to recharge. So it lasts the longest period of time, as well as with Abbott, you are able to do stimulation adjustments virtually. So you can, if you live a distance from your provider, or for some reason it's hard to see your provider, they would be able to do a virtual appointment and actually change the stimulation. So that can be a useful tool, especially if you're not close to your provider.
Yeah.
So
Good points.
think
Yeah.
those
It's
are
so
those
personal. Yeah.
right.
Very
So what's important to you?
right.
I think you could make an argument for any of the
Mhm.
devices, but
Yeah.
and you really can't go wrong. None of them are like gonna be uh none of them are like
None of them are bad. They're all
well,
good. It's just a
right,
matter
right.
of if
Yeah.
there's sometimes there are providers that have, that like to program using one device or another. And then there's also like compatibility with MRI and things like that too, that are sometimes considerations. But you're right. I mean, it's really about the patient and the battery pack and recharging and things like that that are oftentimes discussions about the variations in those devices. So
Right. And they all have like really th- they all have some new features of
mhm,
they're all MRI compatible
mhm,
now, so that's no longer a differentiating thing. And then they all allow us to like steer the stimulation
mhm.
or direct it. And so all of those are um
No longer an
big
issue. Yeah.
advances.
Uh-huh.
Yeah,
Yeah.
yeah.
They've come a long way. Oh, definitely
Yes,
come a long way.
right.
And who would be a good candidate for DBS? That's kind of a tough one too. There is a selection process, and every site is a little bit different on that. I know from my standpoint, from a neurology practice, we can talk about the possibility, but then I would send them to a place like yours to kind of go through with the rest of the team a series of kind of questions, interviews, visits, and things like who would be a good candidate, and how do you guys determine that as a program?
Sure, yeah, I think it is a complicated question, and we bring in, multiple providers to try and
Mhm,
answer that on a patient-specific basis. I think with any elective surgery, you're going to um, basically be weighing what are the potential benefits to this
mhm,
patient and what are the potential risks. And if you move forward with it, you really want it to be a favorable ratio there that we think that we are, have are more likely to benefit that patient
mhm,
than expose them to risk. So, as far as determining what is the potential benefit to a patient, I think thinking about, why is stimulation better than medication? And
mhm,
and for many patients, it's the medicine does a sufficient job
mhm,
where it is benefiting them consistently, or they don't have a lot of untreated tremor, or the tremor doesn't bother them that much. And for, that sort of patient, I don't know that the stimulation would really improve their quality of life that much. And so often we think the risk is not worth it. Um, Now for patients where the carbidopa levodopa is benefiting them, but they are having what are called motor fluctuations, where the medicine only works sometimes and it can wear off. Um, or the medicine might cause an abnormal movement called dyskinesia, where people, are swaying or having wiggly sorts of movements frequently during the day. Um, the stimulation, due to it's like 24/7 continuous nature, can help smooth things out where
mhm,
people are experiencing that same benefit but more consistently. um, and so that would be an example of a typical scenario where we would talk about deep brain stimulation and whether it's a good fit.
mhm,
Um, and then the other reason, which we mentioned earlier, would be just if somebody has a lot of tremor.
mhm,
And that is the case where 30% of people with Parkinson's disease can have what we call medication refractory or medication
mhm,
resistant tremor, where um, we usually try high doses of carbidopa levodopa, and then might try some other medications to see if we can really impact that tremor. But if it's not improving, deep brain stimulation is kind of our best option at that point. And so those would be the two typical scenarios. We sometimes do also do it if somebody's clearly benefiting from carbidopa levodopa, but for some reason they can't tolerate it. So that, you know, sometimes the people's stomachs are really sensitive to the medicine, or there might be, might induce sleepiness or lightheadedness or something like that, where we're really kind of unable to use the medicine effectively. We may consider deep brain stimulation. And then, so those are kind of the patients that would tend to benefit the most. As far as, what are the risks? There is some risk to anyone who undergoes deep brain stimulation, but by and large, people do really well with it. The main typical risks are that there is some risk of infection to the device or the incisions after the implantation. There is a low but present risk of some bleeding in or around the brain.
Sure.
With placement of the device. But there are certain patients at greater risk for an adverse outcome. And the main one is that if somebody has cognitive impairment to the level where they would be classified as having dementia, there is a risk that after the surgery, they have a step down in their cognition. And that is something we certainly don't want to have happen. There also is some evidence that a patient with dementia, may not benefit as much in terms of their quality of life after the surgery, because often the dementia is the main driver of poor quality of life, and the surgery really doesn't address that. So that the presence of dementia would be something that definitely makes it a less favorable surgery.
So, and that's a great point, because you want good outcomes. I mean, you want
Right.
positive outcomes, you want the best possible. And so, obviously, it's a surgery. So, those risk factors are there, like there are with any surgery, of infection and bleed and things like that. But so, give me a little bit of an idea on how you then select, or what do you do? So, you're saying, well, if there's a cognitive impairment, sometimes there are some changes in memory, but maybe not enough to call it a dementia. What kind of assessments are done so that whether you're selecting the right patient?
Sure. Yeah. So if we identify somebody as potentially a candidate, we would do some pre-operative assessments. So these would be one would be seeing how somebody responds to carbidopa-levodopa. And so we would do a standardized exam with them off of their medications, and then with their medications working optimally. And that gives us a sense of how well are they a responder, and that can give us a sense of what symptoms we expect to respond to DBS. And then we do something called a neuropsychological test, and that would be a formal cognitive assessment to see, if somebody has dementia or any form of cognitive impairment. And then we also want to make clear with the patient, like, what are reasonable goals? What are the patient's goals? Are their goals reasonable? And that is a common reason why somebody might be unsatisfied with the surgery, is that we didn't meet their goals. And sometimes that's because their goals were not really what we expect to happen with the surgery.
Apples to oranges, right?
Right. And then we often do a physical therapy assessment with those on and off examinations to see, how does their balance improve with the medicine.
Right.
And then we meet as a group. So we have multiple movement disorder specialists that would meet and watch videos of the patient and discuss their case. And then, if people have certain medical comorbidities that put them at greater risk to have surgery, that would be also often discussed with their medical providers. And we meet in a conference and kind of decide, is this patient a good candidate, like clearly a good candidate, clearly a bad candidate, or, are they somewhere in the middle?
Mhm.
And then would make a decision on whether to offer that patient surgery.
Mhm.
And then we would discuss with the patient, about kind of what we were thinking of their potential benefits and risks,
Mhm.
and then the patient would decide if they want to go through with it. So, it is a process, takes some time. But we want to be sure that, when we do something like this, that
Right.
we set them up for success.
Yeah, that's fantastic. I think that that sounds like a rigorous program, and that's needed, like you said, just to make sure that you have good outcomes and you have good patient selection. Yeah.
Yeah,
What is so after that, after they've decided, okay, they've now decided, you have decided they're safe or they're a good candidate, they'd have that potential for good outcomes, and they're like, yep, let's do this. What happens next?
sure. So they would then meet with the surgeon, go over all the risks, make sure they liked the surgeon.
Mhm.
And then, as far as the actual operation themselves, there are there are a couple different ways to do the operation. The traditional way is to have an awake surgery,
Mhm.
where somebody would hold their medications the day of surgery, and then would have the surgery with the neurosurgeon while awake. And uh, the patient would the, um, have their head in a frame,
Mhm.
and that helps the surgeon be able to target the area they need to. Um, and the other way to do the surgery is asleep. So that would be, the patient would remain on their medications and then be put under general anesthesia, and the surgery would be done while they're asleep. That is a newer way to do the surgery. We don't have clear head-to-head data on which technique is better or worse. They do seem to have similar outcomes. And and so, that decision is kind of made between you and the surgeon. And often certain surgeons prefer a certain technique. Um, Regardless of the technique, you would typically spend the one night in the ICU, and then most patients go home the next day.
Mhm.
And the device is not turned on immediately. We want to allow healing to occur, and there can be some, um, kind of inflammation at the where the lead is placed, that we want that to go down before turning on the device and applying the stimulation.
Mhm.
Um, and most patients do pretty well in terms of like discomfort after the surgery. There is some expected discomfort in the head and neck region. And often patients do utilize like opiate medications for, at least a couple days, but it would be rare for somebody to be on stronger pain medication than Tylenol, after about a week. Sometimes people have some fatigue. Um, but and we usually kind of limit their activities for the first 2 weeks,
Sure.
while they recover. But it's usually not too bad of a recovery.
Mhm.
Um, and then um, as far as the actual turning on the device, that would then be with your neurologist, and usually done 3 to 4 weeks or so after the surgery date. And we call it programming of the
Mhm.
device. So basically, we figure out where along the lead is best to stimulate. Um, and then we usually start with lower stimulation and gradually work up. And that is a process that takes some time. So it's I think everybody wants to see all that benefit right away from the surgery, but it is best to add the stimulation kind of slowly, because it is very powerful and sometimes can induce dyskinesia or cause some side effects if we're too abrupt in adding it. And then the stimulation and the medication, are designed to do similar things. So as we add stimulation, we typically come down on medication. And so it can vary from patient to patient as to whether, like what their medication levels will be, after we get the stimulation optimized. But the average reduction is about 50% for medications. And usually people are not as sensitive and can have, kind of a simpler medication regimen than what they started with.
And that's important to know going in too, because I think oftentimes when people are thinking about getting stimulators, they're assuming there are no medications afterwards as well. And so
Yeah.
it should be set up that they know that it's typical to have medications, but less of them post-op. Mhm.
Right.
Yeah,
I think often patients are attracted by the idea of less
sure.
medications. And it does occasionally happen where patients, do go off medicine, but
Right,
ultimately our goal is to have the best quality of life for the patient, not necessarily to have no medicine.
right.
Um, and we do find that patients generally do better when they remain on at least some medication.
Mhm.
Um, but I often kind of use just the explanation that somebody starts on 100% medicine and zero stimulation, and after the surgery, our goal is to bring up that stimulation and down the medicine, because we because that stimulation is
Constant.
24/7 and constant.
Right,
We'd like that to be the primary thing controlling your symptoms.
right,
Um, and but ultimately the most important thing is that the patient is happy and feels
mhm,
good, um, and, rather than trying to come off medicine
right.
just because we want to.
It's more about that consistency with their day and that quality of life of the day, and how much you can control that between the stimulator and the medications. So
Right.
how often do you normally, if you're working on programming and those medications and tweaking both of those, how often do you normally see people as follow-up after surgery? I know it's dependent obviously on the person, but how long do
Right.
you normally give it
Right.
to settle?
Well, initially it's usually every 2 weeks
Mhm.
until we feel like we've kind of got have things, pretty close to optimized, and then we space it out. So it's usually, the initial appointment, which is a lengthier appointment.
Mhm.
And then uh, we might do like 2 visits that are 2 weeks apart, and then usually it starts to space out some after that. But it is variable, and um, and then typically people are pretty optimized by 3 to 6 months.
Mhm.
And then after that, we would usually see patients on a more typical schedule that we would see other Parkinson's patients. So often 6 months uh, it would be the most common. But often, stimulators do kind of simplify the management
Mhm.
for patients where, now that they have a tool that is very consistent, they're not having as much fluctuations in their symptoms, and any sort of tweaks we make, last. They don't.
Right.
Um, so it's sometimes people are doing so well, we only see them every year,
Mhm.
but some patients we still have to see frequently. So it is kind of um individualized, based on
And
somebody's
there is
need.
a feature on the stimulators that allow us to give some parameters if the patient wants to make some adjustments and things. Some people feel more comfortable with that than others. And how often do you find that people feel comfortable with it? And do you allow that, or do you prefer to do that in office?
Yeah, I think it depends on the patient,
Mhm.
as to how comfortable they feel with that. And how much, um if our gauge of like how risky that could be if somebody is changing it on their own. Um but we often do allow, give patients room to go both up or down within certain
Mhm.
um ranges. And then typically, if we make an adjustment, we would um, put it in we call it a new group, where if they leave the office with different stimulation parameters than what they came in on, where if for some reason they don't feel like they're doing as well on the
Right.
new settings, they can always change it back to the
Mhm.
old settings.
Gotcha.
And so that gives us, some like a little bit of a
Mhm.
safety valve, in case somebody has a delayed side effect
Mhm.
to the stimulation changes.
Super. Well, I feel like this has been really helpful. I think that there's always a lot of questions about deep brain stimulators, what that process is and what they really do. So I really appreciate your insights into that and what your process there at Aurora St. Luke's Medical Center is. If you were to give our listeners, this is an empower talks. We're trying to empower people to kind of take control of their lives and have a say in what they do and how they're treated. If you were to give our listeners one piece of empowering advice, what would it be?
Well, as far as how it applies to deep brain stimulation, I think it's great that you're listening to this talk right now. And I do think education is a great way to empower yourself. And
Mhm.
if you are interested in anything you hear in this talk or in others, to really bring it up at your appointment. We sometimes we as providers don't do a good job of always sort of talking about deep brain stimulation,
Mhm.
but if we are happy to talk about it, and we think it's a great technology. And so if that's something you're interested in knowing, are you a candidate? How would this, help me? I think always, you know, communicating that with your provider, and seeking out the latest and greatest treatments, to try and improve your quality of life. So,
Mhm.
um, kind of a long-winded answer there, but
No, not at all. I think that's a
yeah,
great answer. And it is important for you to know what your options are, and they're not all discussed at every visit. So, and there are a lot of new advances in those options too. So,
yeah, and sometimes we're hesitant to bring it up when because we don't want to scare people. Some people are
sure.
scared about the idea of brain surgery,
Right.
and that makes sense, but learning more about it and talking about it are, I think, the best ways to kind of reduce that fear around it, and really trying to understand, is this a good option for me, and how could it help?
And sometimes it's a matter of just meeting somebody else who's been through it, and so,
Yeah.
reaching out and seeing if we as providers can even gear them towards meeting somebody else that's been through it. And oftentimes we see that with the WPA at our support groups. And that's kind of where this comes from, is that people have different treatment regimens, and what works for one person doesn't always kind of meet the criteria or necessarily work well for others. And so we do want them to have knowledge about their options.
Yep.
I absolutely appreciate your time, Dr. Finseth. I know you're busy, so thank you so much for joining me today.
All right. Thank you.
You take care.
All right.
The Wisconsin Parkinson Association is a grassroots organization funded by people like you. To support more local programming like this, visit wiparkinson.org.